Awesome. Thanks, Jim. Sorry I couldn't be there with you all today, but hopefully this will suffice. If the audio gets wonky, I guess somebody will just call me and we'll go from there. So um, here's my disclosures. So I do fly for SkyWest, but my opinions here and certainly the opinions of Lift Effect do not reflect that of SkyWest Airlines, the American Medical Association, or the American Psychological Association. So there's my disclaimers. All right. So I think there's this perception. We're going to see if it's true or not. When it comes to a pilot's fitness, our philosophy here at the FAA is that it's safer for us to say no than to say yes. Senior legal counsel team member has stated this to me with the promise that I wouldn't disclose who that is. But I think this is what we're up against. I think this is part of that perception of why that perception is there and why that perception is maintained. So we'll just do a kind of a quick rundown of mental health. I know lots of people, most of you in the room are aware of this, but I think it's good to just kind of review it. A mental health disorder is a wide range of mental health conditions. And I think the point here is that health concerns from time to time, everybody has mental health issues, mental health concerns from time to time, but it becomes what we would call an illness when the signs and symptoms start to affect our functionality, and it's on a continuum. Here's some just quick stats on the prevalence. 1 in 5 U.S. adults experience a mental illness each year. 1 in 25, a serious mental illness. 1 in 6 U.S. youth age 6 to 17 have a mental illness, and suicide is the second leading cause of death among people aged 10 to 34. I say that mental health will affect either us or somebody that we know to 100% of the population. So it's a real problem. Types of disorders, anxiety is at the top with about 20%. Major depressive disorder, 7%. Substance abuse, bipolar eating, all the other ones. But down here, any mental disorder, about 20% of the population. This is NAMI's latest statistics. Comorbidity, meaning multiple disorders, is 45%. So just having depression without anxiety, 45% chance you're going to have both, or bipolar, or eating, or substance abuse, so on and so forth. Comorbidity creates a lot of problems with mental health because it can start out as one thing and then it can shift over to something else. Less than 50% reach out for help, and the median time frame is 10 years when symptoms begin to when somebody actually reaches out for help. So people suffer for a long time with this before they reach out, especially when we're dealing with pilots, which we'll talk about. It starts young, typically. It can certainly start at any age, but sort of average onset ages are fairly young, 14 to 24, and the ages are getting younger and younger because people are developing faster. Some of that's psychosocial, some of it I think it's, there's ideas that maybe it's diet based, not sure, but people are getting sicker at a younger age. So fact or fiction, right? Here's the question. Well, I'm sure many of you have seen this study. It's not a perfect study, but there's some decent data within this study. And what it found was, half the pilots actually filled it out, which is pretty high for a survey. 12.6% of those that filled it out met the requirements for the depression threshold on the PHQ-9 score. 13.5%, which is of the 1430 that had flown in the previous 7 days, met this criteria. 4.1% reported having suicidal thoughts within the last 2 weeks. These are active pilots that are flying, and I think the point of this is that this parallels the population. It falls right in line. There's been studies like this that have been replicated, and it's fairly consistent. So our pilots more resilient? It falls right in line with the general population. Do we have the right stuff? Maybe in terms of our personality to be able to do the job, but in terms of resistance to mental health issues, data doesn't support it. Hundreds of pilots currently flying have depressive symptoms. And I think importantly, it says we recommend airline organizations increase support for preventive mental health treatment. Preventive mental health treatment. This is the recommendation. This is probably the most useful thing that came out of that study. I think it falls apart. I think the data shows that it falls apart. So when we think about mental illness, we're looking at progression. Concerns like sadness, fear, worry, stress can become illness as manifested in depression, anxiety, dependency, addiction, and suicide, and it's on a continuum. These symptoms, in terms of this decline in function, look like this: irritability, confused thinking, mood changes, low energy or fatigue, sleep problems, loss of resiliency, and a host of other conditions. But these are sort of the big ones that we tend to look for. This is where that decline in function starts to happen. Barriers to treatment, stigma of being labeled, seen as weak or unstable, certainly with the whole population in general, but when you think about pilots, absolutely. Fear of medical disqualification, which is real. Loss of income and career, which is real. And then limited insurance coverage. Most of the insurance companies, depending on the policy that you have, give 6 months. They might cover a pilot till they're 65, with any other condition, but with mental health, it's 6 months and that's it. And pilots know this, which results in pilots fail to seek treatment. They seek treatment from professionals that are not trained in mental health. Examples that we see in our practice all the time is chiropractors, herbalists, and I would even say even some physicians, they are not adequately trained in mental health. I mean, I think in medical school, a physician gets a number of hours of treatment in mental health that can be counted on 2 hands. So that's an issue. Pilots are unable to find professionals that have experience working with pilots or the FAA, and we'll talk about why this matters. And then pilots ultimately engage in misguided attempts at self-treatment. Buying drugs off the street, buying drugs over in Mexico. I've seen guys buying in China, taking somebody else's medications. Certainly alcohol, illicit drugs are sort of these attempts at self-treatment. So preventive mental health treatment equals early and accurate identification. And certainly in healthcare alone, the movement is preventive medicine, as opposed to waiting for something to become disease and then trying to treat it. So preventive care is what is the goal. That's the target. So let's talk about this progression again, because this is really, really important. This decline in function is what we're looking for. That's the tipping point where we go from concern that's a very normal, adaptive response to something, then becomes non-adaptive or non-functioning because of this decline in function. So that is the target. That's what we want to look for. So when we think about pilot assistance, as we refer to pilot assistance, the question is this where these symptoms show up? Sometimes, but is this the beginning? Well, symptoms manifest themselves in behaviors that we can observe, which then result in consequences that become very predictable. So when you think about these symptoms, this progression, where this lies, the tipping point, behavioral issues is manifested through personality conflicts, sometimes lots of frequent customer complaints, bid avoid lists, frequent flyers in the professional standards programs, people that just are always in there. Reliability issues, excessive sick calls, frequent leave of absences. Unexplained fatigue. Now, fatigue is certainly is real, and it's good that as pilots we have the leverage to call fatigue. I know lots of arguments about 117, whether it was good or not, but I think we can't argue that it gives pilots more leverage to say, hey, I'm not fit, I'm tired, stop building my schedule in such a way that's gonna make me setting me up to fail here. But unexplained fatigue would be where it just doesn't really make sense why the fatigue would be there. Trip shaving is calling out at the beginning of a trip. Maybe pilots had 7 or 8 days off and they continuously call at the beginning, or calling out in the middle of the trip. This affects reliability. And then performance issues, training decompensations, excessive line deviations, and just overall general performance issues. This is where these issues surface. This is where this comes up. That's the decline in function. And we like to call them, we think of them as sort of the ports of entry. It's where they first show up. So in terms of pilot assistance, the flow often is somewhat like this. It manifests in those other areas, and then it filters down into pilot assistance. Certainly with CIRP, that's a little different. After there's an event, if it becomes a clinical issue, then it presents himself at these ports, right? That makes sense? So really, when you think about pilot assistance, it sort of looks like this. Certainly in the way that our pilot assistance programs, I think, as an industry, are set up. But the problem is that they function as silos. And depending on your carrier, we even have, oftentimes these programs are set up through letters of agreement in which they actually prevent them from being able to talk to one another. They isolate the problem and they just keep it there. And so I think what we're finding is that, because mental health problems don't exist in a vacuum, our approach to dealing with them, maybe it shouldn't either. Pilot assistance can and should be proactive, which means early and accurate identification. Again, as that study suggests, early and accurate identification. So Lift Effect does this by providing professional consultation to management, primarily chief pilots, instructors, human resources, labor relations, the people that deal with those ports of entry, unions, meaning, and that's would be within the pilot assistance programs, and then the pilots themselves. And then we also provide treatment to pilots if it's necessary. Our emphasis is to find ways to integrate these services, identify early intervention opportunities, provide preventive care when possible, and then rehabilitative care or treatment when it's necessary. And our aim is to resolve issues in a timely and protective manner before they become career disruptive or career ending medical issues. Now, the way that things are set up is that when it gets to the medical level is, I think, where our hands are tied. We can't really do anything after it gets to that point, which really means once it gets to the AME and gets to the FAA, now you're on the Ferris wheel of getting back. And again, the FAA's stance is that you are guilty now until you can prove otherwise. And, with some conditions, you can get a CT scan, show that things are stable, you go back to work. With mental health, there's no scan that shows that, and it becomes very laborious for pilots to show that they are actually fit and that they can maintain their fitness. And that's how it's set up. So we want to get to these issues before it gets down the medical, the physician pipeline. So what happens under the current model? Well, these issues, these ports of entry, go to the chief pilot's office typically, or human resources. And most often they punish or they forgive. That's, chief pilots tell me all the time, I don't have any leverage other than discipline. And I strongly believe chief pilots don't want to discipline sick people, but that's what they're left with. Pilot assistance programs, I think we do a better job, certainly. If it's resolved, no clinical significance, great. Whether that's, because the peer understood that or not, the result's the same. If it's not clinical, it's resolved. If it's unresolved, well, then it goes to, either the clinical significance isn't identified. It's not to the peer's fault. Maybe they just don't know. Maybe they didn't see it. The issue can recirculate within the respective pilot assistance program. I think pro standards, we see this all the time. Clinical significance is identified, however, the peer fails to refer the pilot because I think some peers, they don't want to throw the pilot under the bus. They don't want to put them down that pipeline. Or certainly less common, but the peer says, no, I can fix this. We've seen this before with peers where they want to help, they're determined that they can help this, but they're delving into something that they're not going to be able to fix. Or the issue gets referred to EAP. So let's just talk about EAPs just for a minute. So the typical EAP process for non-pilots is you find a licensed mental health professional that accepts the EAP insurance. You make your appointment. You attend 3 to 5 one-hour appointments over the next 3 to 5 weeks, and either it's resolved and you go about your life, or you get referred to a mental health professional that takes your health insurance. Well, there's a lot of challenges that pilots face with this. One is finding a mental health professional that accepts their insurance is just an issue with everybody, especially for pilots that might live out in the middle of very remote areas. Many mental health professionals won't treat professional pilots. We see this all the time. I think Germanwings was something that sealed that deal with a lot of mental health professionals. Finding an MHP that has experience with treating professional pilots and working with the FAA can be challenging. There's lots of implications with diagnosing, as well as FAA documentation procedures. Mental health professionals are not trained in that. They're very well intentioned, but they may not understand. You can do that for everybody else, but actually, if you do that with a pilot, that's going to create a lot of problems. Long wait times for appointments. Pilots will sometimes be told 3 or 4 weeks to get in. And if a pilot's going to reach out and want to talk to a psychologist or a counselor, it's probably going to be a time critical issue oftentimes. Pilots' work schedules are not conducive to maintaining regular appointments. See you every Tuesday at 2. That doesn't work when you bid a schedule that changes every month. Most mental health professionals will not use telehealth. It's not reimbursable by most insurance. That's starting to change, but for the most part, it's not reimbursable. Liability issues, licensing board issues, it's challenging for mental health professionals. A lot of them just don't want to deal with it. And honestly, I think this is a big one. The entire process is just intimidating to pilots. There's too many steps. I have looked at the process of signing up for an EAP. Oftentimes it's multi-steps, and I think pilots get overwhelmed with it and they bail. It doesn't convert. So as a result, EAPs are poorly utilized by pilots, as reflected through the very low utilization rates. A successful EAP for anybody in the population might be 3%, and we've seen consistently EAPs that actually get pilots is far south of less than 1% for utilization. So this is kind of pilot assistance, right? And we've got proactive intervention opportunities, I think, up here, and then certainly reactive intervention opportunities down here. And there's not one is necessarily better than the other. We need to be able to do both. We do a great job, I think, in terms of reactive intervention. Once the pilot calls a number, talks to somebody, we move, we know what to do in many respects, but proactively, I think we could do a much better job with this. So let's just talk about lift effects. So we are a practice. There's a sort of a core group of about 5 of us that are either psychologists or professional counselors We've got neuropsychologists. We're even in the process of we certainly have HIMSS AMEs that we like to work with, in the process of recruiting more people. But there's a core of us. We will work. We primarily work with pilots, and we work remotely. So we'll talk about that. So here's what we do, and kind of why people say, well, we have an EAP. Don't we already have that? Well, no. We're pilot dedicated, meaning that's our only clients. Full range of psychological services with this consulting, counseling, coaching, assessment. Primarily telehealth. About 95% is done via the internet like this. In-office is available if you want. Flexible session lengths. It's not uncommon to do 2 or 3 hours for a session, depending on the severity of what's going on. Intensives, multiple sessions over multiple days, certainly with training, decompensations. A pilot might have 2 or 3 days to get it fixed. And so we will work intensely to get that fixed. We do clusters, which is multiple contacts over short periods of time. Video messaging for people that are on backsides of the clock. Email, instant messaging. We just use whatever works. And we certainly work hand in hand with pilot assistance programs. We believe in that team approach. And so pilots find us. This is sort of interesting. In 2014, peer programs were, about 26%. Management, hardly anything. Most of the pilots just found us through other pilots that have told them about us or the internet. 2016 starts to expand, more peer programs, more management. And then 2018, we actually, the scale tipped. And the majority of referrals that we get are through peer assistance programs. So what's good about that is it says that the peer programs are working. Like the pilots with mental health problems are getting to peer programs. And I think that's great. And management is participating as well. So what it looks like is within this structure of pilot assistance, when it's pilot initiated consultation or treatment, we do consultation. There's therapy, coaching, which would be mental management or performance skills. We will consult with other mental health professionals. So if a pilot finds a mental health professional in their area that they want to work with, we will then liaison with that MHP to help them with the documentation procedures and kind of help them through that process. And we can refer out to other mental health professionals as well if the pilot doesn't want to work with us or just wants somebody that's local in their area. We can do that. When it's management initiated, we provide consultation, expanded case reviews, sort of a deep dive into what's going on with this person. Mental health awareness training, soft symptom identification training for management. Program development, we're doing a lot of that. And then company mandate assessments. I think this is a really important piece. Typically, when a pilot is questionable, what do, right? Fit for duty. Well, what's fit for duty mean? That means the FAA. That's how it's written. It means, and again, the FAA and AMEs are going to poke and poke and poke to make sure that there is nothing. It is literally disprove everything, which puts the pilot through a lot. I mean, we just had one particular guy that was fit for duty. I think he was out for 5 months on this to be found fit. 5 months. What a company mandated assessment, and we work with a couple different carriers that are doing that. It's sort of the pre-fit for duty phase. It's, we don't know what's going on with this pilot. We're not sure. Can you take a look? And we can do the assessments. We can do a DOT mirror, which is what a fit for duty is. And then if it needs to be escalated to that, then we'll escalate it to that. But a lot of the time it doesn't. Certainly management's concerned. Pilot assistance programs might be concerned about the fitness of this pilot, but you don't have to get the FAA involved necessarily in this. So, and then when it's pilot assistance program initiated consultation, Again, consultation, call us up. Hey, we've got this person. Is this something that's important that we need to look for? We can do expanded case reviews, again, training, program development, and I'll just highlight psychological support for the peer assistance program volunteers. They are the most neglected group, and it's very easy for them to get compassion fatigue, very easy for them to get lost in the shuffle of caring for other pilots. So that's something that we find ourselves doing. And so what it looks like is this: it's sort of a three safety net model that we're hoping to offer these pilot assistants, we believe that it sort of exists. So the ideal sequence is early identification via management and peers. Phase 2 would be proactive, reactive outreach, ideally from peers. Assessment and treatment by professionals, and then maintenance from peers. And HIMSS does a wonderful job of doing this. They've got it down, and I think we can learn a lot and borrow a lot from the HIMSS model for doing that. And so just to conclude, early and accurate identification of mental health, proactive outreach by management and peers, preferably peers do the outreach, even if it's issues identified by management. I think it's best to have peers do that outreach. Greater transparency and integration of the programs, proper referral to an experienced mental health professional, and then again, management peer outreach, get the professional intervention, and then hand it back to peers for the maintenance. So I think hopefully I got you guys back on track for time. And I'll be happy to answer any questions that you might have. Okay. Okay. No, but we treat a lot of Canadian pilots. We've treated pilots from over, I think it's 26 countries. So we treat a decent amount of Canadian pilots, but nothing set up in Canada. Yeah. Mhm. Yeah. So most of the insurance is not going to cover telehealth, uh, especially when it's across the country. So, I'm on every insurance panel you could imagine, but I would say that I use insurance for pilots maybe 5% of the time. Either the pilots pay out of pocket, or you create a pilot assistance program which then pays for that pilot to get treatment. Yeah. Yep. Yes. Yeah, certainly. And there's this, we've found, and I can talk to you about this, further, but we've sort of found the average sweet spot in terms of the duration of treatment and the number of hours that it takes. Certainly, sometimes it takes 3, sometimes it takes 15, but it's like there is sort of a statistical average of what does it take to treat this pilot, um, and to get them back online, hopefully, or to a place where then they can be utilizing their insurance, getting proper medical care, which is the vast minority, is what that takes. But there is a sweet spot, and I can tell you, to lose a pilot will probably cost more than to do a whole program to just treat the pilots. So, yeah, sure. I do. Mhm. Yeah, offhand, I can't tell. I can sort of do a guess. I mean, I've got uh, there's 5 active JetBlue pilots now. I'm actually, when we conclude this call, I'm doing a session with JetBlue pilot. Um, 5 active. I would say how many in the last year JetBlue pilots have I treated? Probably 20. Maybe a little less, maybe 17 or 18. I have to go back and look. Southwest, I don't know. I don't remember. But and then certain that JetBlue has referred to me, maybe 3. Unfortunately, JetBlue has referred, not to drag out dirty laundry, but has referred after the uncontained failure. And again, at that point, we can help them, but our hands are tied. I mean, it's like the damage is so extensive that it just becomes like just trying to manage the situation and get them to the right professionals. But preventively, like 3, I think, has been actually referred um, through either CIRP or one of the other pilots. Certainly management has not sent any pilots, but to us. But I don't. Again, I think there's not a lot of visibility yet. So does that answer your question, Jim? Yeah. Yeah. Yep. Yeah, they're paying out of pocket. One particular one will do what's called a super bill, and so I'll submit everything to their insurance company, and I'm trying to recall if it was JetBlue or not. Sometimes the insurance will reimburse a percentage of it, but it literally depends on the policy. It's policy dependent. Super bills are not really a very efficient way of getting reimbursement. I know for Delta, there's super bills will they'll reimburse a portion of it, but it's typically out of pocket expenses for the pilot. Yeah. Nope. No, not from our perspective. I mean, we have no reporting requirements to anybody. Now, I do not discourage pilots to not report. That's not, I'm not in the business of that. In fact, what we do is we try to make it so that the pilot, if they're going to report, now do pilots report to the FAA? Come on, guys. I mean, we know that they don't. Pilots don't report. Should they? Yes, they should. And so we try to you know, set up a situation to where they have the best chance with reporting and being able to maintain their medicals. We make sure that the paperwork is done to FAA standards. Absolutely. We're not, again, I said, we're not in the business of putting sick pilots out online. That's not what we do. But certainly, I think getting pilots access to treatment, treating them quickly, efficiently, and competently. Um, most issues are not FAA grounding if it's handled properly. But I think half of the FAA denials for psych-related issues are because of improper documentation. That alone, you know. So, but we're not AMEs. So I don't have any reporting requirements to the FAA. Hmm. Nope. Right. Yep. I'm sorry, with regards to what was the last part? Yes. Yep, we do. We absolutely counsel them. A lot of calls we get with pilots is, hey, I reported this. What can I expect? I got the 60-day letter. What do I need to do? And then we kind of, and we work very closely with Quay Snyder over at AMAS. I mean, their office is a mile from our office. And so AMAS sends a lot of people to us, and we certainly send pilots to, I mean, we're based in Denver. We send pilots over to AMAS to get that. But yeah, we certainly will counsel them on, what does the FAA know? What do they not know? Do they have access to my medical records? No. Do they vet disability? Well, yes, they do. We just spend a lot of time educating pilots, but our goal is to really help that pilot feel like they're in the best hands when they choose to report that they've sought treatment, which is, that's the expectation. It says on the medical, I can't remember exactly what it says, but it's, you are to report visits to medical professionals. Um, yeah, go to the priest and all this, or its family. I mean, it's a mess. But again, it's if the pilot wants to report, we want to make sure that they have the best representation, honest representation. Yeah, yeah, yeah. So a diagnosis is the reason that mental health professionals often will use a diagnosis is, okay, there's one idea that it sort of informs treatment, having a diagnosis informs treatment. But most importantly, a diagnosis is required to get insurance company reimbursement. An insurance company isn't going to pay for somebody to get treatment if there isn't a problem, right? And so this is why most pilots don't want to use their insurance. They know this. Do I need to diagnose them to treat them? No, I don't. Mhm. If they want to, yeah, if they want to run through their insurance, then there has to be a diagnosis. Um, and not all diagnoses are created equal in the eyes of the FAA. And so, we're not going to put a false diagnosis down there, but lots of times pilots will go in and they'll just get, hey, doc, I'm feeling really sad. I lost my dog. Okay, major depressive disorder, single episode. Well, no, that's an adjustment disorder that's totally appropriate. Um, and so, does that make sense? But yeah, if you want to do insurance, that's going to require some kind of diagnosis to be put down on there. Yeah. No. If somebody, well, I have a duty to warn. So if somebody is, as my license requires me, if somebody is going to kill themselves or they're going to hurt an incapacitate a child or an incapacitated adult, or if they're, going to cause harm to somebody else, I have a duty to warn. Do I call the FAA? No, I'll call the police. I mean, have I had pilots that are completely suicidal? Yeah, and I put them in the hospital. I'm not going to help a pilot kill themselves or hurt somebody else, but I don't. I am not obligated to report, call up the FAA. That's that's not where when a pilot is in danger. That's not the agency that we contact to report. Yeah, most welcome. I wish I could be there. So you bet.